So far, we've spent a lot of time talking about T cells in this immunology mini-series, but adaptive immunity is only half the story without B cells and antibodies. This segment focuses on the humoral side of immunity and shows how antibody class, allergy, and immune timing, they all fit into the same overall framework. So B cells develop in the bone marrow, and that's a helpful memory cue. B is for bone marrow. Now, their developmental pattern is similar in principle to T cells, but instead of maturing in the thymus, they mature and develop in the bone marrow. So they're naive B cells when they leave the bone marrow and travel in the bloodstream to the spleen and the lymph nodes. So just as an aside, consider someone who's had their spleen removed. This person may have an increased risk of immunosuppression because they lack this storage site for B cells. In the lymph node, the B cells meet up with the T cells for the ultimate lymph node party. Now, B cells, their main function is to make antibodies, and antibodies are part of humoral immunity, meaning they circulate in the body fluids and bind targets more directly than T cell receptors do. So in the lymph nodes, B cells interact with antigen-presenting cells, APS. And with activated CD4 cells, which we're going to discuss with greater detail later on, these can help them perform more effectively. Now, like T cells, B cells can also produce memory cells. This means the body can make a more rapid antibody response the next time the same pathogen appears. This is part of adaptive immunity. So one practical point to remember is that antibodies are powerful, but if they bind the wrong targets or if they're produced in the wrong context, then they can participate in the autoimmune process, which is, of course, not ideal. So again, the usefulness depends on appropriate control. And if you recall, antibodies bind to infectious agents, and that prevents the infectious agent from binding to other cells. So you're already familiar with strong binding T cells. Those are destroyed in the thymus because we do not want strong binding T cells graduating and then going out and attacking ourselves. Well, slightly stronger binding antibodies may also recognize their own cells and trigger breakdown. So that could contribute to an autoimmune process. So in this way, B cells and T cells might operate similarly. Again, the core function of B cells is to make antibodies, and we're going to spend some time talking about the types of antibodies in a little bit. Okay, so there are several clinically important antibody types. Let's go through them. IgM, IgG, IgA, IgE. Each of these tells us a little something different. IgM, for instance, is usually the first antibody that's made in a new infection. So if a clinician calls for a blood panel, they might be trying to identify or determine whether an infection is recent. In this case, IgM becomes very informative. It's a first-time infection. Contrast that with IgG, which is the main antibody in the blood. It's the one that's strongly associated with memory response, and it tends to persist long after an infection, although levels do tend to decrease over time. IgG is also important because it is small enough to cross the placenta. This allows for maternal antibodies to help protect the fetus. IgA, this is found in the blood, but it's especially important in body secretions. Mucosal surfaces like the airway, the gut, the lungs, right? The bladder, other body cavities. This is an important first line adaptive protection where the body meets the outside world. Now, of note, breast milk contributes important IgA to infants. IgE is the antibody class that we commonly associate strongly with parasitic worms and allergy. Now, in the US, in clinical settings, elevated IgE is probably more likely to make you think allergy rather than parasitic burden. But both concepts matter. So these antibody classes are not just names to memorize, but they give us clues about the timing, location, and immune response. So again, a physician can call for a blood panel to identify the type of antibody present, which gives them a little bit of indication as to what's going on. IgM, first time infection, IgG, we've had this before. Even 15 years later, you'll still have antibodies to the infection. But again, 15 years later, there's going to be less antibodies than there were right after the infection. Of note, IgG is tiny. So when a woman gets pregnant, the IgG passes into the placenta, and this lets the baby borrow the antibody until the baby can make its own. Remember, IgA sneaks into the body cavities, the airway or lungs, the gut, the bladder. Its primary effect to prevent infections that come into areas from the outside world. Breastfeeding, again, as a reminder, would yield primary IgA to the infant, but this can also help to protect the digestive tract and the mucous membranes. Now, IgE, this responds to worms and is responsible for allergies. So worm burdens from Africa and Asia, they trigger IgE to mount a defense against them. Pinworms are the most common in kids, and in general in the US, worms are not all that common. However, individuals relocating from different countries where it is more prevalent may have IgE, and this could tell us a little bit about what's going on in their case. So keep in mind, elevated IgE could be related to an allergic reaction rather than worms. So it could be a peanut allergy or dairy. If a person eats peanuts, antigens that contain these IgE are going to recognize this response and build up in the system. Some patients may identify pollen or certain other foods. Early on in life, when a child is introduced to new foods, the body should recognize that the food is okay. So as early as 6 months old, a blood test or a skin prick test, this can show whether a baby is sensitive to things like peanut antigens and whether or not the baby is going to make allergy-related IgE antibodies that bind to the peanut proteins. Now, this figure does a great job walking us through a hypersensitivity reaction, which is a classic allergic reaction pathway. So let me frame it as a question. What actually has to happen before a person can suddenly break out in hives or have bronchoconstriction or produce an exaggerated allergic response to something like pollen or food? So the first step in this process is sensitization. An initial exposure activates B cells. And on the initial exposure, this is going to cause the B cell to produce allergen-specific IgE. That IgE then binds to receptors on mast cells, essentially arming them for future encounters. The patient may not have a dramatic reaction yet, but the system is being primed. So now, number 2, imagine re-exposure. The allergen comes back. It binds to and cross-links the IgE on the mast cell surface, and that triggers degranulation. Now, histamine, leukotrienes, prostaglandins, cytokines, these are all released, and that is when swelling, bronchoconstriction, itching, other acute symptoms can emerge. So if you're thinking that the story ends there, of course, not yet. Well, there's also the late phase response in which eosinophils are recruited and inflammation can persist. So if you're seeing eosinophilia and allergic history, that should fit this mechanism pretty nicely. So in this figure, of course, we have an example where the APC or antigen presenting cell is identifying and it's binding. We then have an IgE binding with the mast cell, of course, causing some mediators of inflammation. Now, this could be pollen, hives, bronchoconstriction. That's of course what's happening in this mechanism. In the instance where we have eosinophils seen in the blood, if a lot of these cells are present, then they may be an allergic mediated problem. And sensitization, of course, began that process. So some people are more sensitive to things that they breathe in compared to things that they eat. But again, identifying this process, right, with a blood sample could tell you how much IgE is being produced to identify the level of magnitude of this allergic response. I think this is a good summary figure because it reminds us that successful pathogens have to overcome three levels of defense: physical barriers, innate immunity, and adaptive immunity. So if a pathogen gets through only the first barrier, the body still has more layers available. If it manages to persist longer, the adaptive system continues to build a more targeted response. So the timeline shown is especially important. Adaptive immunity is not immediate. It often takes about 5 to 7 days to produce meaningful levels of antibodies and activated effector T cells. So that delay helps explain why a person can feel increasingly sick for days before starting to turn the corner and feel better. So if you were to put this segment together, the story is pretty straightforward. B cells generate antibodies. Those antibodies come in from different clinically meaningful classes. Allergies are one example of an exaggerated adaptive process. And the timing of the adaptive system matters when we interpret what we see in patients. So in the first few hours, of course, we see a bypass of the physical barrier, and now we've engaged with innate immunity. And then over that next 5 to 7 days, we start to see a meaningful response of our T cells. So symptoms can be reflected with this immune cell adaptation. The key point from this section is that B cells and antibodies give adaptive immunity much of its long-term specificity, and that's how we identify the different classes of antibodies. So antibody type helps us interpret what kind of response is happening from IgM, IgG, IgA, IgE. This helps us explain what's going on, and the adaptive timeline reminds us why immune protection does not appear instantly.